Hey guys, this is Randy, and I chose to do my PowerPoint on migraines. We'll go over some general features, phases of a migraine, diagnostic criteria, differentials, treatment plans, and prevention. So let's go. So first, let's go over some general features of a migraine. A migraine headache is the most common diagnosis that patients present with when visiting their PCP. The pathophysiology of a migraine is thought to be because of activation of the trigeminal nerve pathway, which in turn dilates the blood vessels and causes the headache. Migraines are mostly seen in women in adolescence or early adult life. 85% of patients have a positive family history, with first-degree relatives having a significant risk as well. And there are two types, migraine with aura and migraine without an aura, which is more common. So here are the 4 phases of a migraine. The first phase is the prodromal or the premonitory phase. These symptoms can be up to 72 hours before the migraine starts and can include mood changes, fatigue, and yawning. Next is the aura phase. Only about a third of patients experience an aura before a migraine. This can be a visual, cognitive, sensory, or motor symptom that precedes the headache. So some examples of positive symptoms are photopsia, paresthesia, stuff like that. Negative symptoms may also occur, which could include hemianopsia, numbness, trouble concentrating, or even hemiparesis. Some of these are extreme examples, but they could happen. The third phase is the actual migraine, which we'll talk about more in the next slide. Lastly, we have the post-drome phase, which occurs after the headache. The patient is often exhausted for hours to days in this phase. The diagnosis of a migraine is a clinical diagnosis. Usually no lab work is required. This diagnostic criteria on this slide comes from the International Classification of Headache Disorders 3rd edition. So the patient should have 2 out of 4 of the following: one-sided in location, throbbing in quality, moderate to severe pain, or irritated by movement or activity. They should have at least one of the following during the headache: nausea or vomiting, photophobia, phonophobia, and the patient has experienced at least 5 attacks meeting the criteria above, and the headache lasts 4 to 72 hours. I think it's important for migraines to be distinguished from tension headaches and cluster headaches, so I included this slide as a quick refresher for the different types of common headaches. So tension headaches are more common than migraines. They tend to be bilateral. They feel like a tight band around the head. They're mild to moderate in quality, and they're usually caused by stress. While a cluster headache, they're usually severe, unilateral, and periorbital. There will often be ipsilateral nasal congestion, lacrimation, and eye redness. And this typical patient presentation is a middle-aged male. Now let's go over treatment and prevention of a migraine. For treatment of the acute migraine, resting in a dark, quiet room is recommended. NSAIDs or acetaminophen can also be initial treatments for mild to moderate intensity migraines because they can be effective and they are less expensive than migraine-specific choices. If the patient is experiencing nausea and vomiting, adding an antiemetic is appropriate. We'll go over more pharmaceutical options in the next slide. For prevention, the patient should firstly identify and avoid potential triggers of the migraine. Some examples of triggers are heavily processed and aged foods, menstruation, alcohol, stress, or exertion. The patient should get regular exercise and sleep and avoid drastic changes in routine and also limit caffeine. A prophylactic medication is indicated for those who suffer from over 4 headaches per month. And there are many options to choose from, so it is wise to consider the patient's comorbidities and work from there. So here is our treatment and prevention table. As you can see, there are many options for both acute and preventative treatment, so we'll start with acute. NSAIDs and acetaminophen are first line. Triptans can be considered if those first line options don't work, or if the headache is more severe. Ergotamines and CGRP antagonists are other options for the abortive treatment of migraines. And for preventative care, like I said in the last slide, there are many options to choose from, so you should consider your patient's comorbidities. If patients are diagnosed with hypertension, a beta blocker should be started. And an antidepressant like an SSRI or a TCA may benefit patients with depression. Topiramate or valproate may be suggested for people with indications for an anticonvulsant. CGRP antagonists like Aimovig is another option that's a little bit newer, and Botox may even be an option for those with the chronic migraine. Alright, so throughout this presentation, we learned all about the ins and outs of a migraine. I hope you guys enjoyed this refresher, and I hope you guys have a good day.